A 50-year-old gentleman, right side dominant, fell off a curb and then after injured his left digit. He developed a little swelling but thought of little of it and continued to work. Later on, he had another consultation after 6 days with the orthopedic surgeon with the pain in the left little finger. On examination, there was circumferential swelling of the digit. The finger angulated dorsally at the level of distal portion of proximal phalanx. No rotatory deformity was noted. The tendons were intact and the neurovascular status was okay. The patient was otherwise fit and healthy. An X-ray was done which showed a comminuted fracture of the distal portion of the proximal phalanx. The fracture was slightly shortened and angulated dorsally by 35 degrees. There is no intra-articular involvement. A diagnosis was made of an unstable comminuted fracture of the proximal phalanx of small finger. This is an unstable fracture pattern due to the both comminution and obliquity of the fracture. Comminuted unstable fracture of the phalanx, especially the proximal phalanx, are difficult to treat as discussed previously. Often results in limitation of motion and function, regardless of treatment chosen. If open adduction is attempted, it is imperative that the fracture is rigidly fixed to allow early range of motion. Operative fixation should be done on an urgent basis, ideally within the first 10 days to 2 weeks of time. The blood work of a patient was done and was shifted to operative room at 11 days after this injury. A bi-block anesthesia was selected. The patient was placed in supine position with left upper extremity on hand table. A tourniquet was applied at inflated to 215 mm Hg. An ulnar straight mid-axial incision of 4 cm in length was utilized. Careful dissection directly to the level of the bone was performed, achieving hemostasis and electrocautery. A dorsal sensory branch of the ulnar nerve were identified and preserved. The extensor apparatus was left intact and carefully elevated above the fracture. Soft tissue hematoma was removed and curettage. Due to the intracondylar fracture pattern, a mini-condylar plate was selected. Because the size of the phalanx, a 1.5 mm plate was selected. The first step in applying the plate is to pass a 0.045 inch K-wire distally across the condyle in location of the future condylar screw. Its position is carefully checked anterior-posteriorly and lateral radiographed with mini fluoroscopy. A preliminary reduction of the fracture was performed so that appropriate length of mini condylar plate could be assessed. The plate was then bent to match the lateral contour of the phalanx and trimmed to size. The blade of the plate was trimmed to fit the AP dimension of the condyles. The blade of the plate was then inserted to first drill a 1.5 mm hole adjacent to the K-wire. The blade of the plate was then inserted, slipping the previously placed K-wire through the hole of the condylar screw. The adjacent condylar screw was then placed, obtaining bicondylar purchase. Once the condylar fragment was attached to the plate, the fracture was reduced. The fragments were aligned with maximal position of fracture surface. Rotation was carefully checked. The most proximal 1.5 mm screw was placed next, holding the fracture aligned and reduced. Subsequently, the other screws were filled. The wound was irrigated and a closure with 5-0 nylon was done. Plain radiograph was obtained and well-padded hand dressing was applied. The hand was immobilized with a volar or a dorsal plaster splints. The hand therapist reviewed the patient later on and a physiotherapy was instituted. The fracture healed uneventfully and showed a good KLS at 6 weeks' time. An alternate method of treatment in this case can be open adduction fixation with another type of plate or screw configuration, or a close reduction and K-wire fixation. The alternate plates would be a 1.5 or 2 mm mini fragment plate system. Usually these are placed dorsally. These plates may be more bulky and may cause more problems with tendon gliding. Another disadvantage of these plates is the lack of torsional stability afforded by the blade plate. Finally, it is difficult to attain rigid fixation with small condylar fragments with simple dorsal plating. Principles of their application would be similar to the blade plate, that is, fixation of condyles first, followed by reduction and fixation of the shaft to the condyles. Complications which can happen is stiffness, which is one of the commonest complications. Therefore, early mobilization is advisable. Malunion, non-union, and infections are possibilities.